here at the Caribbean Policy Research Institute, Capri. Capri is an independent public policy think tank based at the UWI-MONA. Our mission is to conduct evidence-based research towards improved public policy making in Jamaica and the Caribbean. We endeavor to address issues that are relevant to economic and social development. This evening, we tackle one that is timely and important with the COVID-19 pandemic. Welcome to the launch of the report, Long Shot, aiming to reduce vaccine hesitancy. This report explores the reasons behind the low uptake of COVID vaccines in Jamaica and gives recommendations to increasing demand based on findings from a survey. This report was supported by Blue Dot Insights. Capri's Chief People's Officer, Christina Ivey, will do a presentation on the findings of this report. A panel discussion will follow, moderated by our Director of Research, Dr. Diana Thorburn, with the Honorable Minister of Health and Wellness, Dr. Christopher Tufton, and PAHO representative to Jamaica, Bermuda, and the Cayman Islands, Mr. Ian Stein. We invite our audience to participate in our discussion by using the online platform Slido. Simply browse to slido.com and enter the event code Capri. There, you may post your questions and vote on the polls. We now welcome Mrs. Janae Stevens-Taylor, Head of Research at Blue Dot Insights, to bring remarks.
Dr. the Honorable Christopher Tufton, Minister of Health and Wellness, Mr. Ian Stein, Pan American Health Organization and World Health Organization representative to Jamaica, Bermuda, and the Cayman Islands, Dr. Diana Thorburn, Director of Research, Capri, and our viewers online on YouTube, Facebook, and Twitter. Good evening. Blue Dot is pleased to have been the data collection engine behind Capri's latest effort at encouraging policy stirring thought. At Blue Dot, we are champions of data-driven decision-making, particularly where those decisions have national implications. And as such, we embraced the opportunity to ensure that policies or strategies aimed at encouraging vaccination among Jamaicans are driven by data on Jamaicans. Jamaica continues to trail our Caribbean neighbors in the rate of vaccination against COVID-19, despite the internationally proven safety and efficacy of the available jabs. We applaud Capri for going beyond acknowledging this fact and instead that sought to understand the segments of the Jamaican population that were especially resistant to taking the COVID-19 vaccines and understanding the factors driving the resistance. Using random stratification sampling techniques, Blue Dot ensured a demographically representative sample of adult Jamaicans based on key variables including age, gender, and parish of residence. Data collection featured Blue Dot's digital survey platform and one-click deployment of surveys to numerous tablet devices for interviewer use. The platform also allows for phonetic quality control with tracking and recording functionality and eliminates the need for manual data entry. Our ultimate goal at Blue Dot was to efficiently and accurately collect data to inform Capri's sophisticated analysis and ensure conclusions drawn were derived from sound data. We look forward to the public sharing of Capri's findings and the strategies or policies that they will inform. Thank you.
Thank you, Janice, and it truly is a pleasure working with Blue Dot. We're going to have the presentation now presented by our Chief People Officer, Christina Ivey.
Jamaica has the second lowest vaccination rate in the Caribbean, with only 22% of its population being fully vaccinated since beginning in March last year. This is despite an adequate supply of vaccines. 2 years into this pandemic, the country will almost definitely miss its target of vaccinating 65% of the population by March 31st, 2022. Until this study, it was unclear why vaccine uptake was so low. As such, We sought to determine the underlying factors that contribute to low vaccine uptake in Jamaica, as well as the psychographic and demographic profile of the vaccine hesitant. We did this using a survey of a cross-sectional sample of 1,170 participants across the country. Vaccination against COVID-19 or any communicable disease is a public health good. We have clear evidence that vaccinations reduce the mortality and morbidity of the COVID-19 virus. This benefits not only people who contract COVID-19, but also those who would otherwise be displaced from a hospital bed or whose treatment would be deemed less important. Our public health system, which bears the cost of treating people COVID positive, also benefits from increased vaccination uptake. Increased vaccination uptake means our national economy will suffer less from the productivity losses incurred by people's inability to work. Jamaica's economic recovery has been hampered by the continuation of the pandemic and the measures necessary to control it. This being the case, the government has a clear mandate to procure vaccines and make every effort to promote their uptake in its duty to provide public health goods to the population. Across the world, experience suggests that the factors influencing vaccine uptake are complex and dynamic. There is no single factor which provides an adequate determination of people's willingness to be vaccinated. Our survey results gave us a picture of the typical vaccine hesitant Jamaican. This person is young, low income, did not finish primary school, is not religious, is not complacent, but is risk averse, and does not trust the government or the vaccine. We can further break down the profile of the vaccine hesitant. The survey uncovered that 18 to 24-year-olds were the most likely to be unvaccinated, with nearly 70% of them having not taken the vaccine. This may not be due to any intrinsic difference in age categories, but to their sources of information. Younger people are more likely than older people to get their information from social media, where conspiracy theories and anti-vaccination propaganda thrive. We also found gender was not an important determinant of vaccine hesitancy in Jamaica, unlike many other countries. Education was, however, a critical determinant of willingness to be vaccinated. 46% of persons with a bachelor's degree were vaccinated, compared to only 33% of those who did not finish high school, and 23% of those who did not finish primary school. In the same vein, half the high income bracket had taken the vaccine, compared to just 35% of the lower income bracket. This is likely because less educated people on lower incomes may not have access to high quality information related to the vaccine and may be less able to understand the information they do have, or be subject to misinformation, which is often more digestible. Complacent individuals believe their risk of contracting COVID-19 is low, and that if they contract the virus, they are unlikely to have severe illness. More complacent individuals were 8 percentage points less likely to take the vaccine than those not complacent. Complacency is also strongly correlated with socioeconomic status, where higher complacency is correlated with lower socioeconomic status, and both are correlated with lower likelihood of taking the vaccine. We know this complacency, some of it, is being fed by misinformation. A person's risk appetite was a significant factor in whether they will take the vaccine. 84% of risk-averse individuals avoided the vaccine, compared to only 34% of those who are not risk-averse. A large proportion of respondents indicated an interest in more information about the vaccines and say they would be persuaded to get jabbed if they had more information about their safety in particular. Surprisingly, we found that 47% of religious persons had taken the vaccine, which is 12 percentage points more than non-religious respondents. Convenience was cited as an overwhelming factor in vaccine uptake, where 95% of respondents described some aspect of the vaccination process delivery as inconvenient. While this does not necessarily mean that inconvenience was the binding obstacle to vaccination, since only 4% stated that a more convenient location would make it more likely for them to take the vaccine, the high proportion is still noteworthy. These people could be unvaccinated primarily because of other factors, but the discovery that so many deem it to be inconvenient suggests that the government's efforts are still lacking. A doctor's office is the preferred location to receive the vaccine, followed by a health center. Community centers and schools are the least favored sites to get vaccinated. If even 1 in every 10 unvaccinated persons overcomes their reluctance because getting vaccinated becomes more convenient, the country's vaccination rate would rise by 8 percentage points. Confidence in the vaccine is low. Nearly 80% of those who did not take it indicated that they lacked trust in their government, compared to 36% of people who do trust the government. This historical distrust cannot be undone in a time frame that would have any bearing on the trajectory of the pandemic, but it should be considered with regard to who is disseminating the pro-vaccination messages. Additionally, there is even higher distrust in the vaccines themselves. 87% of the unvaccinated do not trust the vaccine, compared to 35% of the vaccinated. They cite concerns about the newness of the vaccines, their potential harms, or not knowing enough about the vaccines as reasons for not getting vaccinated. But there is hope. 78% said that more information about how the vaccine works, its effectiveness, and its safety would most likely persuade them to take it. The typical vaccine hesitant Jamaican would like more information regarding the safety of the vaccine. They are most likely to be convinced by a family member, doctor, or other healthcare worker to take it, and convenience for them means going to a doctor's office or a health center to get jabbed. We have just 4 recommendations which follow directly from our survey's findings. Firstly, easy to understand messaging and information packages should be created that specifically speak to the safety of the vaccines, their ingredients, how they work, and how they were developed so fast. They should have content to counteract existing and widespread misinformation and disinformation about COVID-19 and the vaccines. This content should continue to use the culturally relevant language, as some vaccination campaigns already have done, to ensure that info is well received and understood by those who need it most. The method of delivery should also be informed by the characteristics of the target audience. Secondly, the role of doctors and healthcare professionals should be emphasized in delivering messages aimed at increasing vaccine take-up. Vaccinated persons should also be encouraged to talk to their family members and persuade them to take the vaccine. Public officials should not be the face of campaigns to increase vaccination, nor the carriers of pro-vaccination messages, given the widespread distrust of the government. Instead, doctors and nurses should be the primary messengers of information related to the COVID-19 vaccine. The majority of respondents cited family members as the person most likely to be able to convince them to take the vaccine. Social media influencers, admired entertainers, and the like might also be enrolled in such efforts. Next, the process of getting vaccinated should be made more convenient and be seen to be more convenient. Doctors' offices and health centers are people's preferred locations to receive the vaccine. While there have been initiatives to increase the distribution of the vaccine via private doctors, this should be continued and expanded. These efforts should be well publicized and the ease of getting vaccinated broadcast widely. And finally, a compensation scheme should be developed for vaccine-related health complications. The government had to indemnify vaccine manufacturers in order to obtain COVID-19 vaccines. Now, they are liable if an individual develops a side effect after taking the COVID-19 vaccine. Injured persons would have to bring a claim against the government in court to receive compensation, but there are usually significant delays in seeking redress through the courts. This being the case, the government should develop a compensation scheme for vaccine-related complications to provide reassurance to those who are concerned about vaccination side effects and are risk-averse. The government should buy this insurance for this risk from a third party. Jamaica's hospitalization data shows that the unvaccinated account for 87% of those hospitalized and 98% of those who have died from COVID-19 related complications. Mass vaccination is the country's best option out of the pandemic. Attaining herd immunity would allow us to curtail the spread of the virus, meaning fewer deaths and lower morbidity, and allowing people to restore and maintain their livelihoods. Going forward, trust, information, and convenience are the three areas that should inform efforts to increase vaccine uptake in Jamaica.
Thank you, Christina. Before we go into our panel discussion with the Minister and Mr. Stein, we're inviting everyone in the audience to go to slido.com and not only ask questions, but also answer our polls. There's a first poll there. We'll share the results at the end. And when you've answered that poll, there'll be a second poll that you don't have to answer right now, but do answer it before the end of the presentation, before the end of the panel discussion. I think it will give some insight into how well we've actually managed to convey the message here. And I'll ask the same question to both of you as well when I get the chance. Before we start taking questions, whether from me or from the audience, I'm going to invite each of you to give a 2-minute response, just an initial response. You'll have a chance to say more later, to this study and the study's findings. I'm going to start with you, Mr. Stein.
Thank you. Thank you very much for having me this evening. It's a tremendous opportunity to join you, people Capri, your team, and Minister Tufton to have this important conversation. I very much appreciate the opportunity. So I think that what we find here is very aligned to the Pan American Health Organization's mission as well, an evidence-based approach towards finding the right path forward. PAHO, the regional office for the World Health Organization in the Americas, is the permanent ally, the evidence-based organization that works with the Ministry of Health here in Jamaica and throughout all the countries of the Americas. And so this permanent relationship is an important dynamic that is a part of this response. We're particularly interested in this study, and we're particularly interested because we know, as your colleagues had mentioned, the fact that vaccination together with social measures, we know are the proven paths forward to get us back to a sense of normalcy. And so as an organization, we are always looking to ensure that we are following the evidence-based to find the right way to overcome the driving issues that are driving the reluctance in the population. So this study that Capri has done, very welcome, as we see that there are many studies that are underway, and I think that all of them are going to tell a little bit more of the story that we need to better understand. While this study has done a very good job to portray a typical reluctant person here in Jamaica, I think we would also anticipate that there might be some lack of heterogeneity on some of these things. I think that this has done a very good step forward, but I think there's also additional information because I think it's reasonable to expect that an older person in their 70s might have different reasons and different reluctance than an unemployed person in their 20s. Or a parent, as an example. So this is a phenomenal and a really important step forward. Thank you so much.
Thank you. Minister, a 2-minute initial response.
All right, so thank you very much to you and Mr. Stein, PAHO, WHO rep here, and of course Capri, for me anyway, represents a very important institution and always doing good work. So I want to commend you and the team for focusing on this very important issue. You know, the findings are quite interesting, and I'm one who believe in research, data-driven analysis and decision-making. And as the policymaker for public health, I'll certainly review and ask my team to review these numbers, and we do take them seriously. Generally, the position clearly from our perspective is that vaccines are the most important response to COVID-19. The vaccines that have been administered, certainly in Jamaica, have gone through rigorous tests and trials by WHO experts and others. And it is unfortunate that the take-up rate, which now is probably just over 660,000 Jamaicans who are fully vaccinated, of the 2 million or so that we have targeted, is well below what we would like. You know, when you get into the further discussion around the numbers, there are a couple of things that may require some exploration. One is that the perception around vaccination and the extent of hesitancy has to be dissected around a few critically important things, some of which you have mentioned here. The trust is a big issue. Risk is a big issue. Timing is a big issue, which may not have been mentioned in the study. And the administration of the process, the ease of access, which was mentioned. I think the timing issue is important. And perhaps, you know, I would have certainly liked it to be more included in the process, because the perception around the vaccination program in the early stages of COVID, when the vaccine at that time was not actually available, when the risk was perceived to be highest, people had significant fears, but the vaccines were more concentrated into parts of the world, the developed world, to my mind, created a missed opportunity for take-up for us. Later on, as the risk became perceived as not as intense, and the noise around vaccination and the anti-vaxxers, and even in the medical fraternity where there were mixed views, it created a trust issue, not just among the policymakers, but generally speaking. So while I fully appreciate and fully endorse the study and the findings, and I believe we should take it seriously, I think there were some other issues which I'd like to bring into the conversation.
Yeah, certainly. Thank you, Minister. Just also want to remind viewers that not only can you pose questions, you can also vote up questions. So if you see a question that you think you want to hear answered, you can vote it up. And on my side, I will see it at the top of my list of questions. Some of the questions that are asked already kind of speak to some of the things that both Minister and Mr. Stein said in terms of the granularity of the study. It was a survey. We weren't able to get into issues of why schools were not favorable places or seen as convenient. But I think that idea that, you know, at the outset, most of the vaccine blitzes and drives were in community centers and schools. And we didn't have this data to know that people didn't know that schools were inconvenient or not convenient for people to take the vaccine. So I'd ask you, Mr. Stein, and then I'll give you the opportunity to answer as well, Minister. What is perhaps one or two things from the study that you say that if we had known that then, we might have done differently?
Thank you very much. I think allow us to reflect on a particularly important issue around vaccination programs in general. When we do vaccination programs, while this particular time access to the vaccine itself has been difficult, historically, we see that the hardest part of vaccination programs are getting vaccines into arms. Typically, you have the vaccine available, whether it's measles, the range of different routine vaccination. And the difficult things for many governments across the Americas has been to get vaccine into arms. And so typically speaking, when we look at these things, it is an issue of access, getting it to the point of access where people feel most comfortable. Certainly here in Jamaica, the challenge that was early on that Mr. Tufton mentioned, and I agree that the timing is a very important issue, the small numbers of vaccine that were available during the early months of this meant that the people that were going out to access the vaccines were going to go wherever those were. So we're at a different stage in time now, and it's really listening to this type of program, this type of research to say, where do people most favorably look to go to get their vaccine? So the research suggests that people want to go to doctors' offices, they want to go to health centers. those are places where vaccines are largely available through the programs that the ministry has put forward. The public-private relationship and getting medicines, vaccines to doctors has been a tremendous step forward. Health centers, obviously a routine place for this. So I think that the challenges that we see now are challenges that we often see in getting the vaccines into people's arms.
What would you say is one or two things from the study that if you'd known that, then you might have done a little bit differently?
Well, I think that the study is useful from the standpoint of the extent to which we create greater access points. To have done that in the very early stages would have been a function of, as I said earlier, the availability of the vaccines. Because when we actually got the vaccines or started getting it, quantities were small. And so what we actually did was to use those the best way we knew how, using the traditional methods and the traditional outlets for distribution. We have a very strong immunization program in the country. And that immunization program has been fairly successful. Our Human Development Index, life expectancy and so on, is largely linked to that immunization program. It comes with a protocol around how vaccinations are administered. Yes. It is the primary healthcare nurse. That protocol is almost culturally sacrosanct. It is holy territory, holy ground. And one of the things that I encountered, certainly as minister, and I think the process encountered, not to take away from the people, the public health team that have been involved, because they did a good job, is that there was a lot of hesitancy in releasing that protocol. So creating more space for non-traditional outlets to administer the vaccine. And it actually took some time to get there. And I suspect that that contributed to some of the perceptions around convenience. Because there was a view that we needed to follow the protocol. Now, in a crisis, you have to adjust. And in hindsight, in relation to your question, I think I think we probably should have pivoted earlier, which would have addressed some of the concerns around access.
Well, I think that's correct. We did the survey in September. So by then we would have started to have the supply of vaccines. And the people who really wanted it would have gotten it already. And now it was time to reach the people who weren't going to get it. I think another significant thing that we found, and this is not unique to vaccinations, but I was surprised by the extent to which it affected the vaccination process, which is the issue of the low trust in government and in the vaccine. And we did a box pop that I think would be a nice way of introducing a discussion on this. If we can have the box pop on trust.
No, I'm not vaccinated. Why aren't you? The reason I'm not vaccinated is because I don't know, I can trust the system, because I need to do more research on the whole vaccine thing right now. So I'm not sure.
Right. So PAHO did a study before the vaccination program, which predicted a low take-up, not as low as it actually was. It was 35% was the prediction, and we're at 23. Was trust factored in? Did you recognize at the time that trust would be such a serious problem in the vaccine uptake?
I think there's a risk here of trying to simplify things that are actually very complex. Right? And so certainly trust is going to be a factor. And the trust in the vaccine, the trust in authorities is something that we're seeing across a broad range of countries, not just in, as you've seen here in Jamaica. So for us, the issue is we are looking at how there is this change in what we would call the social contract. Right? Your obligation as being a part of society is building in a part towards the public health approach. And so that, I think, marries with this issue of trust, because I think as we've seen over the past several years in many different places, in many different countries, that this issue of a belief in what has been a traditional approach traditional source of information has changed with the new information age that we have it. So it was one of the pieces that was there. Yes.
Minister, I know it must not be nice to hear that so many people don't trust the government. Were you aware of how profound this feeling was and how that would translate over to the vaccination uptake, the low vaccination uptake?
What I saw in this study, and it confirms my suspicion based on my experience, is that the trust issue was not just about government. It was also about the process. It was also about the vaccines. And that lack of trust, to my mind, was fed not just by the traditional low ratings of government, and the legitimacy of governments all over the world is under threat and is being challenged. And indeed, the polls leading up on other issues suggests at one point that the Ministry of Health had a stronger legitimacy in arguing the COVID response than the government itself, which supports the view of the health workers, the CMO and others who carried that messaging. But the reality is that the landscape in modern times have significantly adjusted around social media, which allows for a lot more voices to be heard. The anti-vax movement, to my mind, we in public health globally have been complacent, I think, about, and they have become well-resourced and a lot more forceful in their argument, and this provided an opportunity for them. And even in the medical field, trust was eroded because credentialed individuals, medical doctors, were arguing the pros and cons of to vaccinate or not. So you're right, it's a very complex issue. It's difficult to compare our own circumstance with other jurisdictions because context has a lot to do with it. I mean, in the developed world, the vaccines were available in the very early stages. In some countries, much more rigid laws were passed around vaccination as mandating it to access certain services. And we decided not to go that route. And that also had to be placed in the mix. So I agree with you and with the study that trust was a big issue. The issue is in moving forward, how do you counter those elements or variables that go into creating that distrust?
Yeah, I think that the mixed messages, to put it nicely, of medical professionals was probably particularly damaging, given that the study said that the person or the source of information or who was most likely to be able to convince them after a family member was a doctor or nurse. So that was particularly, a lot of dynamics going on in creating that lack of trust, where the trust figures were the ones also speaking out against the vaccine. At the 18 to 24 age cohort, the study has identified that as the most resistant. What is being done and Mr. Stein mentioned that you have to have different messages for different target audiences, but they're not only the ones who are least taking the vaccine, they're the ones who are moving around the most and who are likely to be the greatest transmitters. I think when the BPO had the first mass outbreak, the concern there was these young people were going to be super spreaders, and so you had to take that very unusual move of quarantining these hundreds of young people in a state quarantine. What is being done now with regard to vaccination and that kind of problematic cohort?
Right. So bear in mind too that the vaccination program started by targeting the more vulnerable age cohorts. So we started with the 60s and over and frontline workers early in the narrative, when vaccines were seen as a true savior for them, having seen many deaths leading up to that point. And so the take-up, the energy and enthusiasm around take-up was greatest there. That did also have an impact on the take-up rate of the younger cohort, that cohort that you mentioned, in that they, I believe, bought into some of that narrative, whether rightly or wrongly so, that the real risk resided with the 60s and over, their grandmothers and mothers, not with them. And in a sense, we fed that narrative because we have always said, and in reflection, we probably shouldn't have done that. We have always said that, you know, it's not the young people. When we started to make the connection between the spreaders, the super spreaders of the young spreading it to the parents, is when we pivoted with the messaging. Now, we are and have seen in recent times, certainly with the variant strain, not the Omicron strain, but the Delta, where younger people are being affected more. And I think it boils down, therefore, to risks and how we explain those risks, and not just the risks of COVID, but part of the narrative that has been developed out there is the risks of your, you know, capacity to produce, you know, your agility, your, you know, all of the things that go into creating a cultural dynamic, a belief system that could carry significantly decision whether or not to get vaccinated. So what we find ourselves doing in the communities now are one-on-one interaction. So we have expanded now into community-based activation, using community leaders, young leaders, to be a part of the outreach. And hopefully that kind of interaction at that level, rather than in the air, will have a greater impact to address some of the concerns of that young cohort.
Well, the study does say family members. Family members are the key source of ability to convince people to take the vaccine. Would you consider something like some kind of a campaign or initiative or effort to not only have young people and peers pushing the message, but getting family members who are vaccinated to convince, maybe providing them with helpful messaging? Is that something you would consider?
Absolutely. I mean, if the study supports that, and we do believe in the data and the analysis of the data, we're certainly prepared to rethink the approach. We do have young people currently in the media, advertising, communication space promoting the value of the vaccines. But you're right, to the extent that we may need to do that more, I have no difficulty looking at that.
I want to take it a little bit broader, Ian, with regard to the rest of the region. Jamaica is the second lowest in the hemisphere. From what you've gathered, I would like to think we're one of the first to do a study like this. Maybe there's other data out there. Issues like the 18 to 24 group being the most resistant, and doctors and family members being the most trusted sources. To what extent are you able to see that? Is Jamaica unusual? So we're unusual with regard to gender. So we, globally, women are more resistant than men. But in Jamaica, it was almost the same, a statistically insignificant difference. Are you seeing any differences between Jamaica and our specific cultural context that the minister referred to, and what's obtaining, whether elsewhere in the Caribbean region or in the broader Latin American and Caribbean region?
Thank you. There is other research that has been done in the Caribbean. We were discussing this recently amongst colleagues within the Pan American Health Organization. And I think that one of the key issues that has emerged, and I'm hopeful that this is the same case here in Jamaica, although that's to be determined, is that there's actually research that suggests there's a large group of people that are still willing to get vaccinated. And I think for me, that actually is the most important issue that we have to best determine. So in terms of consistency, I think there's a lot of commonality where people go to where to get information, who they trust. There's consistency in the Caribbean in that respect as well. I think that it's important to note that we often, in this particular context, national context, we focus on the fact that Jamaica is the second lowest in the hemisphere. However, the reality is the fact that of the lowest 10, the vast majority is in the Caribbean. And so there is commonality that is important to talk about in the Caribbean context. Certainly what takes place in Jamaica, the local context, is the most important piece. And so that's why this study is particularly important as we dissect this and compare it to other places. And another piece that I think I would just like to pick up on is that it's important for us to continue to learn, right? We have seen this type of study, important place to guide us in our interventions. It has these studies and others before them have allowed us to say, where do we need to make change to address the challenges that we have? I think learning is a healthy thing. We often think of the challenges. I remember my mother saying, this is going to be a learning experience. And I'm thinking, like, I could do with less learning experiences. But these are important for us to pivot, as the minister has said. And these are all good things.
I want to bring up the issue of mandates, vaccine mandates. It's not something that we directly addressed in the study, but we inferred from the findings what the implications might be for a vaccine mandate. And before I give you a minute to think about it while we play a box pop, which speaks to what happens when people feel pressured or compelled by somebody else to take the vaccine. If we could have that box pop.
Are you vaccinated? Yes, I'm vaccinated. I take the Johnson. The Johnson & Johnson. Okay, what were your side effects?
Well, my side effects would give me a little pain and a little fever, you know. And I take some Panadol to recover from that.
Is there a specific reason as to why you took the vaccine in the first place?
Well, apparently work system, and what the government did say, type of work what I do, I have to really require to do. So it's not really forced to do it still, you know, but it's the way of the system. You understand? So I guess they are saying that it's a better way to do that by taking the vaccine. So I really go ahead and do it.
Yeah, so he took it, but the system made him do it. What's the view right now in specific contexts like Jamaica, the Caribbean, on mandates from PAHO and WHO?
So it's an important question around mandates, and important to understand the role of the World Health Organization and the Pan American Health Organization. With regard to mandates, of course, we see the effect of them, the outcome of how it changes behavior and vaccination uptake. However, the role of the organization is to make recommendations to governments, and governments to decide what is the most appropriate thing in the local context. Up to today, the WHO and PAHO have both been consistent in saying that these types of things, that the decision on taking a vaccine should be an individual choice. We understand the effect of mandates, and we respect that there are member countries to make the decision that's actually most appropriate for them.
Minister, there are countries like France where overnight the vaccine uptake multiplied exponentially because the government announced that if you weren't vaccinated, you weren't going to have access to restaurants, museums, and so on. What's the current thinking here?
Well, there's no change in the current thinking, which is obviously very different from France. Again, I agree with Mr. Stein that the individual respective governments have to make their decisions based on their particular context. We never really contemplated mandates in the strictest form, like France, or as an example. We have, however, taken decisions around access to certain activities or events, like sporting events, if you're vaccinated, in terms of our borders, testing to enter, as other countries have done. So in a sense, we've had a sort of hybrid approach, and that approach for us was important because we do believe that the circumstances of how our society is structured, our culture, may create levels of dislocation that would perhaps outweigh the benefits that we would seek to achieve. And it's something that we deliberated a lot over, but clearly came down on the side of the current position. Now, one could argue that it may have resulted in a low take-up. I'm not so sure, to be totally frank.
There's a question from Slido about public sector employees who have received the jab, and is there any data? This survey did not disaggregate for what sector people were in, but we are aware, as the minister and Mr. Stein would be, that there has been a disturbingly low take-up, particularly by public sector healthcare workers. And when we shared the study with our stakeholders, that came up also as a very significant problem. What's the thoughts on, you know, is this something that you need to be researching more? Have you figured out how you're going to address this in the Jamaican context? And then I asked you, Mr. Stein, to just talk about that from a more regional perspective.
Well, you know, what's interesting about the data around public health workers and take-up is that traditionally, health workers have had very low take-up of vaccines. I mean, each year with the flu vaccine, no matter how you encourage it, the take-up is generally very low, maybe in the 30% or so. In fact, we waste a lot of the flu vaccine. That's something we make a headline over. In this case, the take-up has been higher than usual. In fact, if you speak to the respective associations like the NAJ, Nurse Association of Jamaica, they tell you that they're close to 70 or so percent. Our impression, based on what we have seen, is that the take-up is somewhere in the region of 50 to 60% of healthcare workers, which still leaves a large block that have not taken the vaccines. We've tried a number of things. I mean, we've tried to address the risk factor through small groups, through encouragement, using the very same leaders in the space. It had some impact, but not the level of impact that we would like. And there's a general view that if you are a healthcare worker, you know the precautions to take. And so you will mask up, you will sanitize, you will do what. And there's also a fair degree of distrust, unfortunately, with the vaccine itself, because there is a view that it's not as tried, tested, and proven, which we have tried to deal with. And so we've had to face those challenges, but we continue to encourage.
How is PAHO treating with this very serious issue in the vaccine rollout?
Yeah, for us, it's actually, there's a number of disturbing aspects to this. Let us recognize that, as an example, nurses, they are a group that is a subgroup of the population as a whole. We would like them to have a positive approach towards vaccination. And one of the reasons why it's so important for us to have them have that positive approach and take actions in getting the jab is because we know the trust factor that people are turning to these people to make their decisions. However, we recognize, as the ministers mentioned, that there's trends that we see in this respect. And the trends that we see with the public health employees, which are beyond nurses, not just nurses. And it's important to make that distinguishing between the types of professions that we're talking about. But there's long-term trends about immunization overall. And I think that that's another issue that is really concerning for us. Because while we're talking about COVID today, we should be keeping our eye on other issues. We need to be talking about measles rates. In a very disturbing situation, we have to recognize that our coverage on polio, which has been eradicated for a long time in the Americas, the coverage rates for polio is significantly lower than we want it to be. And these are all issues that they're dots that are connected. And so while we talk about public policy and we talk about the impact on certain sectors, these are all troubling indicators that we can't let our guard down. Dr. Etienne, the regional director for WHO and PAHO's director, her press conference earlier this week, that was the theme, was we can't let our guard down now. There's too many things that are uncertain about the future. And we can't let our guard down on COVID, and we have to revisit our guard on other routine immunizations as well.
Okay.
Can I just say that you know, I'm probably not, as a member of the governing body for public health, PAHO, WHO, one of the lessons coming out of this experience over the last 2 years is the extent to which we have to mount a much more assertive challenge to the alternative view around immunization or vaccinations generally. I believe the world has lost ground there was a time when 99% of a population got their vaccines as a routine. In some instances, we mandate it obviously by law going into the school system. But there is a sort of nibbling away of that belief. And I think it's not a country problem. I think it's an indication that we have a much bigger problem. And perhaps this generation has forgotten the benefits of vaccination and immunization against traditional threats. Maybe we need to start being more deliberate. And I personally, as a Minister of Health, in the halls of the region and the hemisphere and the world, intend to voice my own opinion around that, because I do believe that that is one of the big lessons coming out of the COVID experience.
If I may.
Please.
Spot on. I mean, what we are hearing from our ministers of health is this issue, that we need to revisit how we are approaching one of the foundations of public health around the vaccination. We know it's one of the most cost-effective interventions there is to address disease. And so we hear this consistently from the ministers of health, your colleagues in the Caribbean. We hear it through the region. And I think that what we are also recognizing or trying to internalize is that where we have been successful before was success in a particular time, in a particular context. We are in a different time, a different context. The access to information and the information pandemic, right? The overload of information requires us to revisit how we are adjusting our strategies to make sure we have the similar outcomes that we've had in the past. The Americas is the leader, has historically been the leader in vaccination. And so I think that we need to look at this and own it ourselves and be the leaders in the future to say, how are we going to show the rest of the world how to address this challenge, this new challenge to the public health?
Okay. So this is my last question before we wrap up, and it's a two-part question. These are from Slido. So Ian, for you first, and then you can follow up, Minister. What do you guys think about the data released by Pfizer about the mountain of side effects that are associated with the vaccine? And then, Minister, I'd like you to follow up with your thoughts on the feasibility of an insurance program to cover side effects and complications from the vaccine.
I often think about these things not as a public health person, but as Ian Stein. I have taken many decisions in my life that are risk-based. And typically speaking, I'm probably more accepting risk of many other persons. However, for me, when I look at vaccination and I consider the risk versus the reward, it's clear to me. And so for me, I am very pro-vaccination. I often reflect on which ones I have not had, not the ones I have had. And so when I hear the challenges and the new information that we see coming from manufacturers, I have to reflect, does it change my mind? And the answer is no, because we still see that the adverse issues that have come out with new information is still a small percentage. We are talking about billions of doses of the range of different vaccines that have been applied around the world. And the challenges that we're seeing are still a very, very, very small number.
Right. So, you know, it's interesting that the side effects are highlighted, and they're highlighted more out of a requirement, particularly when it comes to this type of product, drugs. The laws require every side effect to be highlighted. It doesn't require that level of scrutiny for a can of beans, which comes with its own potential side effects. So for the sort of critical, analytical perspective, the truth is it boils down to the risk that every aspect of life represents and the reward that a decision around a particular aspect of life provides. And there is no doubt that once vaccines go through the traditional process of experimentation, clinical trials, expert review, which is what we have done in Jamaica. We did not take vaccines that were not WHO approved, emergency approvals, but approvals nevertheless. We are comfortable that historically that process works and the good is far greater than the side effects. So the answer to that question is that while I acknowledge all of that, we stick with the science and use the science to achieve the greater good. And I think we're on good grounds when we do that. Now, as it relates to an insurance arrangement, if we could, in a sense, the government does have one. We have free healthcare. So we provide support to anyone who is ill in our health institutions. And that has to be borne in terms of a cost. The kind of compensation that would involve maybe a payout beyond the medical response is something that was not thought of during this period because it would involve many actors. And in an emergency, you tend to prioritize your response. I don't think we had enough time during that period to conceptualize this kind of quote-unquote insurance arrangement. But we did assure the public and continue to assure the public that any adverse effect or impact would be treated as a matter of priority. And it's actually a part of the vaccine protocol.
So we kind of de facto have that in a way.
In a sense,
okay.
Yes.
So our last question, we have 3 minutes and we want to wrap up on time. And I'll ask Ian to answer first and then give you, Minister, the last word. There's a sense in Jamaica now that we've kind of already gone back to normal. The traffic is back to, I think it's worse than it was before the pandemic. How are we going to convince Jamaicans that vaccines are still relevant? What do Jamaicans not know that they ought to know, why we still need to continue to push for people to take vaccines?
If I reflect on this, for me, as we say, the proof is in the pudding. If we look around the world and the countries that have managed to move forward and to return to some sense of, I don't know if the word normalcy is the right word, some kind of next phase, those are the countries that have the highest vaccination rates. And when we have the opportunity to see what is taking place in other countries, and we see the opportunity lost here, it's worth noting. What are we missing here? The central question that you're asking. For me, the issue is the ongoing risk. Variants are what viruses do. And so for me, I consider that the ongoing risk of a potential variant that is as transmissible as others with other further serious repercussions is one that we have to reinforce is a real risk.
Okay.
So I do believe that the challenge ahead as it relates to vaccine hesitancy or overcoming that is that much greater, with the threat being perceived, real, or perception to be less, and particularly among the cohorts that have the lowest take-up, the younger people. So I think it's a big task. I think our approach has to be to continue to provide and make it easier for access, as your study have suggested. So we're now discussing access through more private physicians and basically compensating them for providing the vaccines. The fixed sites, so people who go to the health centers as a routine would have the access. And beyond that, I think it's important for us to continue to track the virus itself and how it is evolving, whether as less of a threat or more of a threat, whether through a variant strain or otherwise, and provide, in a sense, the impetus, the motivation based on heightened alertness and risk for persons to take up. I think risk ultimately, or the perception of personal risk, is going to be the key driver, not necessarily access, because if people don't perceive it as necessary, but particularly in our culture where small things like the sight of a needle is a scary prospect, it is going to make it difficult. So we are going to have to keep the message, push the influence, monitor the threat, and provide the information. And I think hopefully that will lead to further take-up. But it's a tall order. That's the reality.
Okay, thank you both. The last thing we're going to ask you, our viewers, thank you for the great questions that you put, is to answer our second poll on the findings of the study. I'm going to turn back over to Dominique, who's going to take us out.
Thank you, Diana, and thank you also for guiding this rather enlightening conversation this evening. We would also like to extend thanks to our panelists, Dr. Christopher Tufton and Mr. Ian Stein, for joining and engaging in this evening's discussion. We'd also like to say thank you to our corporate sponsors and thank you to our audience for tuning in. We have one final request of our audience, and it is to go back to Slido and rate this evening's event. Be sure to look out for the launch of our upcoming reports on financing tertiary education next month. Tonight's report is available on our website at capricaribbean.org. Once again, thank you for joining us. Have a good night.
You know who have the gun them. Stop go like you don't notice. You notice.